It's an T1 image with contrast. It was started on preventive treatment, propranolol. Again, it's a low dose, 30 milligram daily for 1 year with partial improvement of the headache severity, but still it was daily headache. Which improved was the headache severity and the associated symptoms. Patient then was maintained on topiramate 25 milligram daily, citalopram 20 milligram daily, and cinnarizine 75 milligram daily for 1.5 years with no further improvement. A patient also received botulinum toxin and occipital nerve block with no improvement. The current situation, the patient has near daily headache of mixed migraine and tension days. Most of the days it's migraine days, with daily use of about 1 to 2 tabs of either non-steroidals or triptans, and is on zonisamide 25 milligram daily, olanzapine 5 milligram daily, paroxetine 25 milligram daily, and cinnarizine 25 milligram daily. Thank you.
Quite interesting. So, I mean, the fact that this issue with pulmonary sarcoidosis will really can complicate matters. And the first question came to my mind. So we established that this patient has got a past background of episodic migraine before the issue of pulmonary sarcoidosis and chronification. I would be interested to know what were the symptoms that she had that led to the diagnosis of pulmonary sarcoidosis. I'm not quite sure that I heard it right. Did you say that was proven by biopsy?
It was proven by lung biopsy.
Lung biopsy. And then, in terms of temporal relationship with sarcoidosis, which one started first?
The diagnosis of pulmonary sarcoidosis started first. Then, after a period of months, the headache started to
get worse.
Be chronic and get worse.
And the MRI scan was done with contrast or without contrast?
With contrast and without contrast. She did multiple MRI scans with contrast, and then nothing was revealed. She mostly was falsely diagnosed as neurosarcoidosis, as appears from the images, just patches.
I mean, I don't think it would be fair on me to comment on just a few images from the MRI scan, but ideally the MRI scan would have been with contrast, and usually would be looking for some kind of meningeal enhancement, for example, at least.
No.
So that's number one, because the word kind of neuropsychosis is a kind of a big diagnosis, not to be taken lightly.
After the lumbar puncture, what's the evolution of CSF? It's a little bit mixed. I mean, I'm just confused. So, if it is sarcoidosis and neurosarcoidosis, it has to be proven or excluded.
Okay.
But now it's just in the middle. It goes nowhere.
Yeah, she came to us.
And afterwards, why it's 1,500 milligram of acetazolamide? Why what was the reason?
Actually, she came to us with this presentation. We didn't start this. All this was past history for us. All this treatment she received was presenting to us with this history. We didn't do this for
okay,
this.
But do you have those records? For example, for the ACE. For example, what's the ACE level in the plasma and also in the CSF?
Excuse me, I didn't.
Angiotensin converting enzyme.
Acetazolamide. I can't gather this.
So, for example, the angioconverting enzyme levels in the CSF and plasma, whether that has been looked at?
Yeah, for diagnosis of sarcoidosis.
Yeah. Of neurosarcoidosis?
Neuropsychosis.
No. Whether that has been checked in the CSF?
It was checked, but it was no increased ACE levels. It wasn't increased.
Okay, we don't know really about the patient's habitus and whether there are any orthostatic features of that headache, whether it gets worse on laying flat. But if there's nothing to suggest that, I mean, that CSF pressure is not.
So, I mean, we've only seen a few images, but of course, let's not forget that there's an increased prevalence of white matter lesions, as some call it. I personally don't call them white matter lesions. I call them white matter hyperintensities in migraine patients. We don't like to call them lesions because we don't really know whether they cause any pathology. So to me, on the scans, there was no typical localization for neurosarcoidosis, such as hypothalamic involvement and so on. So I'm not really convinced, but I can't exclude neurosarcoidosis. But I think you should be careful with the diagnosis. Second point, the CSF pressure was 24 centimeters.
Not high.
Nowadays, we consider the upper limit of normal to be 25. That's one thing. And the second thing that I haven't heard is the presence or absence of papilledema, because most patients with increased pressure will have papilledema. So it leads to a few more questions. Was this patient obese? Is it an obese patient?
No, no, no.
No, okay. Because, I mean, you may just catch someone with migraine chronification and obesity, and is really an epidemic in the UK. The number of idiopathic intracranial hypertension is really, really on the rise. It will be globally. So that would be a differential diagnosis for migraine chronification. Again, I must admit, maybe we overstress this, but again, this is a patient that is not on contraception. In Belgium, we would not do this. This has happened for many, many years. For example, topiramate, to comment a bit further on that, is now moved into FDA, so in the US, risk category D, which is, you know, you only have the worst is X, which is really an absolute nightmare if you use drugs like that. But so there's a number of drugs here that you really want to avoid in women that can become pregnant.
No, I just want to make clear it's not, we meant here no oral or hormonal contraception, not total contraception.
I see.
As they use IUDs.
I see.
Yeah,
okay,
yeah.
okay, that's
not
very different.
not total,
Right.
yeah.
So, I mean, to come to a sort of interim conclusion, because we can't really discuss neurosarcoidosis, which would be a very different situation. But from the epidemiological point of view, the most likely diagnosis would be, again, migraine chronification, and as been discussing before, should be looking for a lot of risk factors and so on, and the management should be accordingly. A second thing to consider in many female patients, especially when they're obese, is idiopathic intracranial hypertension. But as I've said, the pressure is still within normal limits, and you have to be very careful whether the pressure measurements have been done in a fully relaxed situation. So patients have to stretch their legs, actually, because in many places they get the instructions to really bend into like a small position, but legs should be outstretched, and patients should be breathing. This is a high upper normal limit value, and neurosarcoidosis again requires more evidence.
Can I add a point, please? I would agree with all of you for the following reasons. Let's make very quick review. She had migraine since the age of 13, and she's 39 here, and she's multifactorial, and looks like migraine. The pressure is at 24 at 4 is not that high to use acetazolamide or whatever. If that was an autoimmune or whatever it is, she only received a local occipital block or a steroid block, which is she did not have received enough IV steroid or oral steroids or whatever. The Topamax she used, the Zonogram she used, such a little doses, and she used with it Cipralex and multiple medication that added more in the conifications, and even the olanzapine she used, it went all of that. Let me be the devil advocate here. If she does not really have a bad neurosarcoidosis, where it will have more marks, stroke-like, seizure-like, other issues like, but she didn't, what I would have done, and I thought of an autoimmune process, I would hit her with a high dose of steroid. I would hit her with high Topamax, up to 100 milligram, 200 milligram, up to 400 milligram, because it will lower the intracranial pressure and it will lower the CSF pressure, because the pressure here is only a touch of 24. That there is a question of weight and other stuff. So I'll be aggressive on my anti-epileptic. I wouldn't go to Zonigram and Topamax and Cipram and olanzapine. I will do high dose of Topamax. I will do IV steroid for a few days. I will then do steroid tapers. I maintain her on a high dose of Topamax, and then I could use PRN, Cirqual, Quantipine, and stuff like that, and that goes to the things. If I'm going to be the devil advocate, but I really think this is a chronification of migraine and has nothing to do with others.
Okay, thank you. Any questions?
What about the current options of treatment of this patient? How can we manage?
Well, again, you mentioned it's a mixed headache, so my first question would be whether it's really fulfilling chronic migraine criteria. So are there at least 8 days of migraine per month? Second question would be whether there's, again, medication overuse and potentially medication overuse headache. So we would choose according to the phenotype. If it's chronic migraine, again, we would have, in a world without money, we would have botulinum toxin, for example, or in the UK where it's reimbursed. There's very little evidence based apart from topiramate and botulinum toxin for chronic migraine. Withdrawal, as we've discussed, risk factor management, that would be the way forward. Of course, my first approach would be if there's is still a doubt about this neurosarcoidosis. I mean, that's the first thing to address, of course. That may mean repeat scanning with gadolinium and to see whether there's any enhancing lesions. The fact we haven't heard the CSF data, but I assume the CSF composition was normal. There was no inflammatory changes in the CSF.
No.
So, I mean, if there's still a doubt, I would do an MRI with gadolinium.
Yeah, I would first go to the diagnosis. If it is a solid diagnosis to prove, or I have to exclude the neurosarcoidosis, whatever it is. And the second one is there really intracranial hypertension or not? And if not, you can repeat the lumbar puncture and look all those details. For example, CSF glucose level is also very important. Or the cellular composition, or etc. I would like to comment on something. For example, the mixed headache is not the correct diagnosis. There is no mixed headache. For example, for such a person who is having the chronic migraine headaches, she will never have mixed type, tension type, and chronic migraine headaches at the same time. This is one of the problems with the tension type headache diagnosis also. If you look at the pure tension type headache patients, they never mix, but people usually mix the tension type headaches when they occur in the chronic migraine patients, when during the chronicity, the migrainous features, when they are blunted, that can be mixed with tension type. But this is, migraine, not tension type. Okay.
So one final comment on the potential increased CSF pressure. My screening examination would be fundoscopy, and now in our region, optical coherence tomography as an additional test is actually put forward. For those of you who are interested, we've just produced a guideline on idiopathic intracranial hypertension by the European Headache Federation. You can download it for free from the Journal of
That's
Headache and Pain.
nice.
It's just maybe helpful.
Okay. Thank you. This is the last case, and I would like to thank all the chairs and all the attendees. Thank you.
Thanks.
Thank you, everyone. That concludes the conference. Thank you for being here. Thank you for joining us, and I hope you enjoyed it. And see you soon. Of course, as we agreed, April 2020, probably, inshallah, Turkey. And until then, we hope to meet in several meetings. We hope to get you again to Egypt somehow in the next half year. So thank you, and see you again. Bye-bye.